To Cape Town, South Africa, the most beautiful city in the world. I'm Stacy Stender, Chair of the Coordinating Committee of the Scientific Activities. I'm thrilled to see so many people here today. At this 46th World Union World Conference, we have made a strong commitment to hear the voices of civil society and affected communities. This year, we have the first ever community space, which is free to the public for anybody to visit, hopefully a lot of local people. And appropriately, it's here in Cape Town, South Africa. I would encourage you to go and spend some time in Imbizo. It's in Hall 4B, a space where communities involved in the fight for lung health are coming together for discussion, support, learning, and inspiration. The Imbizo would not have been possible without the work of Zolani Barnes, the chair of the local organizing committee, and TB HIV Care Association, the organization he works for. He and his team have worked tirelessly to bring Imbizo together, and it gives me great pleasure to welcome him to the stage.
I'm not going to take all the credit. So I have my team, which I would like to invite to the stage right now. Can the team that I worked with please join me on stage right now? Ladies and gentlemen, good evening. My name is Zolani Barnes. I work for TB HIV Care Association. And if the team can please make their way, all those that are here. And thanks, Stacey, for that introduction. So Imbizo is basically called by traditional leaders. So I had to be a traditional leader and call those guys together. Now you're called to end TB. So it's a gathering of like-minded minds. All what we want to do is basically end TB. So some of the highlights just to tempt you and get you to come and visit our space. And I must say, Stacey, it's much more fun than your conference. So we have high-level updates just to tempt you a bit. So Mark Darble's going to be there. So we have 9 symposia. We have 3 workshops. And these workshops will be looking at, MDR TB. We'll be looking at advocacy, human rights, HIV and TB in prisons. And what we'll also be doing within that space is basically address stigma and how to basically engage communities and integrate communities in civil society. I know some of you will be sitting a long time, so we have a soccer pitch, so feel free to come and kick TB out of South Africa and the rest of your country. So Vienna is showing you how that is done. Can I kick some of them? No. Vienna, no. What is, What is also exciting, ladies and gentlemen, is that we have a wall mural. So I know I've seen some of you have been there and basically pledge your support. And it's basically to highlight pediatric TB. So take some time and basically go and see what is happening over there. Now at this point, ladies and gentlemen, I would like to just mention the organization. I don't think they're all here, but the organizations that are here. So it's TB HIV Care, which is myself. And the team that I was working with, particular Michelle Carey. Living Hope is here. All right, we have Treatment Action Campaign somewhere, Tech. All right, we have TB Proof, she's coming on stage right now. Sonke Gender Justice. Western Cape Department of Health. We have Oram Innova, Mothers to Mothers that we worked with, Grassroots Soccer. Eris is also here. And I think lastly, ladies and gentlemen, I think I'd like to thank the organizers. This is the first time. We're very nervous. This is the first time we had to do this thing. And with this team, we managed to pull it together. So please make some time and go to the Imbizo. It's the hall right at the end. It's 4B. And it's very exciting. And also, thanks to the union. And thanks, Stacey, for your support. And thanks to this lovely team. Please give them a round of applause. Thank you very much.
I'm Jane Carter, the President of the Union. Welcome to Cape Town and welcome to the 46th Union World Conference on Lung Health. A new agenda. That's the theme of this year's conference. When the scientific committee chose that theme a year ago, I wonder if they realized what a year would bring. A month ago, WHO published the Global Tuberculosis Report 2015. The good news is that TB mortality has come down by 47% since 1990, with almost all of that gain having occurred since the MDG goals were set in 2000. The terrible news is that TB still kills more people each year than any other infectious disease. And at the current rate of progress, it will take 200 years to end TB. We need a new agenda. The global plan to end TB was published a few short weeks ago. The title of the plan, The Paradigm Shift 2016-2020, notifies all of us that there is indeed a new agenda. Let me quote from the introduction of the paradigm shift. TB has persisted throughout history because its roots are deeply intertwined with economic and social inequities. TB has always been a disease of poverty and a litmus test for our commitment to social equity and health for all. Unfortunately, its longevity has created a sense of acceptance that is here to stay. This is totally in line with the mission of the Union, Health Solutions for the Poor. To quote the global plan further, the global plan sets to smash the status quo and provides a way to address these challenges through scaling up and integrating TB care into a wider health and community systems approach to eliminate poverty and build healthy, sustainable societies. There is a new agenda here. And I hope that you're going to see that throughout the conference in the next few days. Visit the Imbizo space that you were just hearing about. We expect about 800 members of civil society to visit the Imbizo space daily. I describe this space as a space of translation, and I don't mean only language translation where scientific presentations will be translated into local language. But this is a place where science meets activism and translates into the end of TB. This is the new agenda. The Imbizo space would not have come about without new partnering, and you just heard about the 10 local South African NGOs who came together under the leadership of Zolani Barnes of the TB HIV Care Association to work with the scientific committee to make this happen. Activism and science, the new agenda, new partnerships, new ways of doing things, a paradigm shift. This year, the Union is 95 years old. Our history is best honored by taking the lessons of the past and applying those lessons through new thinking to the same problem our founders faced, a global TB epidemic. Know, share, act. This is what the Union does. In 3 words, that's what this conference has always been about and will always be about. The problems are clearly before us. 9.6 million ill, 1.5 million deaths a year. These numbers galvanize our action. This pattern ends here. TB ends here. The paradigm shift, the new agenda, starts here. I hope to see you in the corridors. I hope to see you in the sessions. I hope to see you in the plenaries. I hope to see you in the Imbizo, planning your role in the new agenda. There is no place for complacency in these halls. Welcome to the 46th World Conference on Lung Health. Before we continue with our ceremony, I just want to take a minute to remember close friends of the Union who have recently passed on. One of the foremost leaders in 20th century public health, Dr. Annick Rouland, joined the Union in 1956. Over the next 36 years, she went on to serve as both the Director of Scientific Activities and the Executive Director before she retired in 1992. She lived and breathed the work of the Union, and her legacy permeates everything that we do today. Craig Cloud was a brilliant, creative, tireless TB advocate and a close friend of the Union for many years. He created the DOTS brand, as well as the Empower brand, which is the international standard for tobacco control. Craig was a mentor and advisor and trusted colleague to many of the people in this room. Please stand with me for a moment of silence in their honor. Thank you. It's now my pleasure to introduce Jose Luis Castro, the Executive Director of the Union.
Thank you, Jane. Minister of Health, honored guests, members of the Union, ladies and gentlemen, representatives of the civil society, the Union World Conference of Lung Health is pleased to be here again in South Africa. We have returned to stand with the courageous people of this country, our brothers and sisters, to tell them that you are not alone in fighting the battle against tuberculosis, HIV, and the health crisis that you face. We are here to help, to raise our voices, to let the world know that we stand united with you, to show respect for the people who truly understand the meaning of the word commitment, and to remember Nelson Mandela, Madiba, who said that it always seems impossible until it is done. Members and colleagues from around the world, more than 4,000 of you that will join us in this year's conference from 120 countries, you will participate in one of the most pivotal conferences in the history of the Union. You are here because you understand that defeating tuberculosis, HIV/AIDS, and tobacco will take hard work and determination. It will take skill. You have come because you are committed to our fight. This is a pivotal world conference on lung health. We are moving into a new era for global development, for global health, and for TB and lung health. The world has committed to ending tuberculosis by 2035, and the recently adopted Sustainable Development Goals include, for the first time, non-communicable diseases like cancer, heart disease, and diabetes. And the recognition that tobacco, which is a major driver of these diseases, must be a priority. The World Health Organization NTB strategy is entering its first year of implementation. And the Stop TB Partnership's new global plan to end TB, a 5-year plan to help implement the global strategy, is opening its new phase. So, it is a new era of action, an era of urgency. Our conference theme, as Jane pointed out, is a new agenda, Lung Health Beyond 2015, a theme that challenges us to respond with resolve and to act. Through the next 5 days, I encourage you to keep our theme in mind and these 5 imperatives. First, We must build political will and engagement to ensure increased resources and well-prepared health systems. Second, drug-resistant tuberculosis. Many countries remain ill-prepared against this epidemic. Existing treatment methods remain intolerably long and difficult and not successful enough. Third, the TB, HIV, and TB diabetes epidemic. If we don't, this crisis will push communities into suffering, disability, death, and poverty. This is a global development issue. Fourth, we need new tools to fight these epidemics. And we need to be innovative, unafraid to test new ideas. We must transform lung health globally. To end TB, we need a paradigm shift in our response to it. I believe that this conference is where that will come to life. The paradigm shift calls for a larger tent full of all stakeholders playing their part to end TB with renewed energy and with greater resources. What we see and learn here will guide us. We will receive research updates on a new regime for treating multi-drug resistant tuberculosis, one that shortens the treatment length from 24 months to 9 months. This will be a game changer. We will hear reports on TB in prisons, a health emergency in many countries that we must address now. We will learn about significant and largely undetected TB strains originating in animal populations that are now affecting people. And this is a very worrisome development. Earlier this week, we hosted the Global TB Summit, a gathering of parliamentarians from 30 countries to support our efforts to end tuberculosis. We will focus our attention on key affected populations, and as has been mentioned before by Solani and by Jane, Imbisu is a space here within our conference for all communities affected by lung health to gather and to share. And I urge everyone to visit Imbisu frequently. I spent this morning together with Prabodh about an hour meeting the participants at the Imbisu space. We are all here, the finest minds and leadership in our global community, researchers, doctors, civil society, policymakers, patients, advocates, the industry, and the media. Together, we will forge this paradigm shift using our collective knowledge, evidence, and experience. Finally, as you walk through this conference venue, you will see a photo exhibit of TB survivors from across the globe. Take a moment to see them. Read their stories. They represent everything that we strive for: courage, hope, and resilience. Let's start a new journey in South Africa, the settling of one of the greatest struggles in human history, one that started with huge challenges, as did the fight against tuberculosis a century ago. May we rise to conduct our struggle in the same determination, spirit that the people of this great land brought to theirs. Remember, it is always impossible until it is done. I thank you and I welcome you to the 46th Conference of the Union.
His Excellency, Mr. Cyril Ramaphosa, Deputy President of the Republic of South Africa, was scheduled to be with us tonight. He sends his deep regrets, but was called away on urgent business by the President. I am thrilled to, however, welcome a close friend and great partner to the Union, the Honorable Minister Dr. Aaron Motsoaledi, the Minister of Health for South Africa and the Chair of the Stop TB Partnership Board, who will be delivering the inaugural lecture composed in collaboration with Deputy President Ramaphosa. As many of you know, Deputy President Ramaphosa played a key role in negotiations that ended apartheid. He also helped coordinate the release of Nelson Mandela and has been one of South Africa's most prominent leaders, both here and on the world stage. He has been a tireless advocate in the global movement to stop TB, and this year, along with Dr. Motsoaledi, he helped launch a national TB screening program here in South Africa. Dr. Motsoaledi was also active in the liberation struggle in college and as a medical student. He later became a provincial deputy chair of the ANC and served on the Limpopo Provincial Executive Committee of the ANC for 19 years. He was then elected to the ANC National Executive Committee, where he serves today. We are lucky to have Dr. Motsoaledi working so diligently to end TB here and setting an example for health ministers around the world. I am pleased to welcome you to the stage to deliver the lecture entitled Turning the Tide Against Lung Disease in South Africa.
President of the Union, Dr. Jane Carter, Executive Director, Jose Castro, ladies and gentlemen, delegates, members of civil society, good evening. As I've already been introduced, I'm standing here for the Deputy Head of State, our Deputy President, Mr. Cyril Ramaphosa, who up to the very last minute was prepared to stand here in front of you. Unfortunately, it was never to be. But since his speech was already prepared and said, I'm going to read it just as it was prepared. Dear delegates, on behalf of the government and the people of South Africa, we extend our heartfelt gratitude to the Union and its board for bringing this conference to our shores. The conference takes place a few days after we marked World AIDS Day, where as South Africans, we rededicated ourselves to fight HIV and tuberculosis. We have taken a pledge that together we shall rise, that collectively we shall act, and that as a nation, we shall protect ourselves from HIV and TB. On Sunday, it will be 2 years since the father of our nation, Nelson Rolihlahla Mandela, passed away. A TB survivor himself and a father who lost his son to AIDS, he became a global champion in the fight against TB, HIV, and the stigma associated with these epidemics. Addressing the International AIDS Conference in 2004, Mandela said, I open quotes, "The world has made defeating AIDS a top priority. This is a blessing, but TB remains ignored. Today we are calling on the world to recognize that we can't fight AIDS unless we do much more to fight TB as well." Close quotes. In the history of the human race, TB has killed more people than any other disease. From its founding in 1920, this union has dedicated itself to fight this disease. Over the years, the union has become a vital strategic agent in the elimination of tuberculosis and lung diseases. We applaud the outstanding leadership of the union, which refuses to accept that quality health care and effective treatment should be available only to the privileged few. This is a union that is committed to accomplish public health care. It is driven by justice, care, and human solidarity. It is a union that recognizes that the well-being of one is the well-being of others. This position resonates with the objective of the South African government. South Africa is committed to the ambitious Sustainable Development Goals on TB and other diseases. We are already working hard to ensure that by 2020, we find, that means screen and test, at least 90% of people with TB in the general population and 90% of TB in the most vulnerable groups, and achieve treatment success of at least 90% in both the general population and the vulnerable groups. It is indeed our power to attain the vision of a TB-free world. A sense of agency and purpose is required if we are to end TB. South Africa launched a massive TB screening campaign in March this year, the 24th of March, World TB Day. Special attention is being paid to prison inmates, minors, and people living in communities that neighbor the mines. We have even calculated our figures. We know for now that the people in correctional services in South Africa are 150,000. And in terms of the 90% of them must be screened. We know by now that the people who are working in the mines number 500,000, that's 500,000. And in terms of the 90 again, 90% of them need to be screened. We already know that people living in mining communities in the top 6 districts out of South Africa's 56 districts, which have got very high mining activity, the people there number 4 million. And we believe 90% of them, again, must be screened. Since the screening process started in March this year, we have conducted 517,000 screening procedures among the 150,000 inmates, because they are screened on entry 2 times per annum and when they get discharged. Among the miners, we have hired 9 inspectors who go from mine to mine to make sure that the mining houses themselves, using their own resources as a contribution to the fight against TB, conduct the screening. I'm happy to announce that the 9 inspectors have informed us that 90% of the mining houses are conducting the screening. Among the peri-mining communities, we have already conducted 600,000 screening exercises. We are using GeneXpect and digital X-ray machines in this screening. Since 2014, South Africans who visited clinics are routinely screened for TB. We are focusing on getting those who are infected onto treatment, better integrating the management of HIV and TB, enhancing multi-drug resistant TB control, and addressing weaknesses in our primary healthcare system. South Africa has recently concluded HIV and TB investment cases, which studied the impact and cost of an extensive range of known interventions against TB and HIV. It confirmed that by scaling up currently available tools we can significantly reduce the number of people who are infected with TB and reduce mortality. However, to end the TB epidemic, we need new diagnostic tools and drugs, which require far greater levels of investment to which the global community must commit more resources. This is a watershed moment in the battle against TB. For the first time, we are witnessing a concerted effort to get political representatives of the people globally to get involved in the fight against TB. We applaud the members of parliament from 102 countries who recently signed the pledge drafted by the Global TB Caucus. We were humbled to host the first summit of the Global TB Caucus in Cape Town a few days ago, attended by members of parliament from 40 countries. The caucus served to mobilize MPs to add their voices and contribute their leadership to help rid the world of TB. This is unprecedented. Apart from treatment, we need to do more to create awareness about lung-related diseases and how to prevent them. We are all required to do more to control the sale of tobacco and to protect non-smokers from its harmful toxins. We urge governments, civil society, and citizens to be more aggressive in the fight against tobacco use. I wish you all the successful conference, and I look forward to your participation at the 21st International AIDS Conference, which will be held in Durban next year. Thank you very much.
As someone that has called South Africa home for more than a decade, I say Nkosi Kakhulu. I understand you have to leave before perhaps the end of the opening ceremony, so I also say Ambagahle when you do go. Now I'm going to, are my slides up? Yes, they are. Talk to you a little bit about the conference briefly, so you know what's ahead of you for the next 3 days. I know many of you have already been here several days, but the scientific conference begins tomorrow morning. I just want to give you an overview of how the Union Scientific section works. We have 4 sections: TB, tobacco control, adult and child lung health, and HIV, and there are 3 subsections: bacteriology and immunology, nurses and allied professionals, and zoonotic TB. These are the 7 scientific contributors to developing the program. We also involve civil society, so there are 8 of us, 8 plus myself, 9, that work diligently to get this conference going. Just a schedule at a glance so you know what's happening while you're here. This is the Wordle with all the titles from the symposia and the abstract sessions, as you can see. So you can see what the focus is of this conference. We have 6 regions, 23 tracks, 31 oral abstracts, 74 symposia, 14 workshops, 11 postgraduate courses, 88 poster sessions, of which 15 are e-posters, trying to move with the times, the new agenda, maybe use electronic rather than printing posters, 8 Meet the Expert sessions, 13 sponsored satellite symposia. The only other thing I wanted to say about the conference program is the closing ceremony on Sunday is going to be open to the public in our attempt to truly engage civil society. So during the rapporteur session, anybody that visits the Imbizo is welcome to come and learn what happened during the 3 days. My final words are in memoriam for this woman, Rhea Grant. She passed away 2 weeks ago. Her impact on TB control and empowerment of people living with the disease occurred at the global level through her leadership as communications focal point for the developing country NGO of the Global Fund. Nationally in South Africa for the past 40 years, many people know her. I know Honorable Motsoaledi knew Rhea well. And here locally in Cape Town, where she led a local NGO and dedicated her life to providing support for patients and families affected by TB. We didn't end TB in her lifetime, but hopefully we will in my lifetime if we are equally passionate and driven as Ria was. Now, I would like to introduce to you our next speaker. Her name is Juliet Nalumu. She's a site coordinator for Mothers to Mothers from Uganda. Mothers to Mothers is a group that trains, employs, and empowers mentor mothers living with HIV to work alongside doctors and nurses and understaffed health centers as members of the healthcare team. The ultimate goal is to eliminate pediatric HIV and AIDS and improve the health and well-being of mothers, babies, and families. They have already reached more than 1.3 million HIV-positive mothers in 9 countries in sub-Saharan Africa. We are honored Juliet is here with us today, and I welcome you.
Good evening, ladies and gentlemen. My name is Nalumu Vivian Juliet. I work with Mothers to Mothers Uganda as a site coordinator in Kamoli Mission Hospital in East Central Uganda. I'm here to share with you my testimony, or rather personal experience, as how I managed to overcome TB and HIV to live an empowered life I'm living now. It all started in 2006 as pregnant for the first time. I was 26 years old by then, with my first pregnancy. And I went to this hospital where I happen to be working now for the normal antenatal care. As a routine, all pregnant women were being screened for HIV. I had all the joy, the pride, the anxiety any new mother would have. And I didn't bother. I went for the test. In a few minutes, all the joy, happiness, and anxiety that I had to disappear when a midwife told me I was HIV positive. My first thought was, who would take care of me? My mother had died of HIV in 2003. Those are 3 years earlier. And as the biggest girl in the family, I took care of her throughout her death, up to her death. So by being HIV positive, I knew where I was heading. The midwife advised me to share my test results with my husband because I needed a lot of support to raise and produce an HIV-free baby. Let me tell you for the moment about my home life. I'm one of my husband's 3 wives. In that part of the country where I come from, it is normal and acceptable for a man to marry more than 1 wife. He is the breadwinner and takes all the important decisions in the home. A woman's role is to do housework, produce children, and be silent. My greatest worry was, as the youngest and 3rd wife, if I told my family about my new diagnosis, they could easily put the blame on me and probably kick me out of the home and would have nothing to live on. I decided to keep quiet. It takes around 2 hours from the hospital to my home. The midwife had given me some drugs to carry home that I was supposed to take on a monthly basis. As I traveled back home, I was looking out for a way I had to take these drugs, but without the knowledge of anyone, not even my husband. 1 month down the road, the medicines got finished. And in the village down there, people believed that it was only important for a pregnant woman to go to the hospital twice. You go once for the first antenatal booking, and you only wait to go back to deliver. So having failed to tell my husband about my new diagnosis, it was quite hard to keep going back to the hospital. I never went back. After 5 months, I started becoming very sick. I remember I was carried back to this very facility at 32 weeks of gestation and only weighed 45 kilograms. That's around 92 pounds. I was very sick. I lost too much weight. I had a very bad cough, fevers that never went on, and all the symptoms of TB. On admission, I was tested for TB and I was positive. The midwife explained to me well about my added diagnosis because I had HIV and now had TB. She told me how important it was to take these drugs well, now that I was pregnant, such that I don't transmit the disease to my baby, my new unborn baby. But she did not understand the challenges I was going through back at home that hindered me from adhering well in the first place. I didn't take the drugs very well. I had no support of my family and I was very weak. I could take some days and miss some doses. 2 months down the road, I gave birth to twin baby girls. My first twin started becoming very sick when she was only 2 months. Her skin peel off as though she had been burnt by water. She had a very bad chest infection. She had lost too much weight. And I only managed to take her to a nearby clinic where she died at 4 months. At 9 months, my other little one also started developing similar symptoms. I rushed her this time to hospital. She was admitted with pneumonia and also tested positive for both HIV and tuberculosis. There I was. At first, it was me alone who even failed to manage myself. But now I have an innocent little girl that I have to take care of. I tried to talk to the health workers about my challenges. And I even became more determined to keep my girl on treatment and take the drugs that the doctor had prescribed. Sometimes I could fail, but because I've now explained to them what was happening, they could bring me drugs at my home. We kept on struggling like that until 4 years later when Mothers to Mothers came to Uganda and opened up a site in this very facility where me and my daughter were getting treatment from. One of the midwives who used to bring me drugs home came to my place and told me of an organization that was recruiting HIV-positive women like me to act as role models and peer educators to fellow HIV-positive people. I applied and for a job and I was hired as a mentor mother, a job opportunity that turned my life all the way around. During the first training, the Mothers trainer told us how important it was to tell your family, because being a mentor mother means telling other people about your HIV status the way I'm doing it now. And it becomes very hard, if not impossible, if you've not told your own family, because they will have to find out from other people. I seeked her support and we disclosed to my husband. He was tested and was positive too, and his other 2 wives were also tested, and one of them was positive, and the 2 of them were started on treatment. I now had the support of my husband in addition to the support of the family. I also had the financial and social empowerment. Life kept on improving. After some time on job, I wanted to try out the messages I was giving to other women. I got pregnant again, and I'm happy to tell you that I have 2 more children who are not only healthy, but HIV-free. I also managed to enroll in a local university in Uganda, and in October last year, I graduated with a bachelor's degree in social work and social administration. Currently, all pregnant women in Uganda are being screened for HIV. I strongly believe that if everybody would be screened for HIV the same way for TB rather, the same way they are screened for HIV, it would be equally important to say that TB is diagnosed so early and probably interventions are done at a very early stage that would help save lives. Mothers work so hard to ensure that the women who happen to be HIV positive get the education and support that they really need to take their drugs and stay on treatment forever, exhausting all the challenges that could be existing amongst them. In our one-on-one sessions, we probe further to see if the mother is symptomatic for TB. A call for a pregnant lactating or pregnant woman is a sign of TB to us. and we refer such women to healthcare providers for further management. We look for the same signs and symptoms for TB by asking the 5 probing questions in all HIV-negative women that we interact with. Mothers is also trying to make TB screening and referrals stronger at community level, where community mothers visit women who have not accessed maternal and child care services or have missed key important appointments in their homes. Having someone from the community to come to visit you at your home and discuss sensitive issues like TB, HIV, in privacy of your personal home often reduces stigma and fear, induces the fears of stigma so that women can get the treatment they need. My work gives me a lot of fulfillment. I know firsthand how important it is to diagnose and treat TB and HIV. If I could do it over and over again, I would have made every effort to stay on treatment and save my baby from HIV and probably AIDS. Knowing that I've helped even a single woman save her child from AIDS or TB gives me a lot of fulfillment and keeps me going. Besides that, there's something else, something bigger that I'm part of. Mothers to Mothers has given me an opportunity to participate in the global struggle against pediatric tuberculosis and HIV that reigned the life of my lovely baby girl. Now that I'm more empowered than ever, I'm doing everything in my capacity to educate, support, and empower all women in my care to ensure that no more babies get infected from HIV, and nobody, irrespective of status and age, should die of TB rather, because it is curable. Thank you so much, everybody that is helping me do that.
Thank you, Juliet, not just for sharing your story, but for sharing your courage and your leadership with all of us here today. It's always a highlight of the conference to be able to celebrate and recognize individuals who have made an outstanding contribution to TB control and lung health. We'll be presenting several awards, sponsored both by the union, by our members, and our partners during the conference. Most of these are going to be presented during the plenary sessions. Today, however, we will award the Union Medal. This is the union's highest honor awarded to members who have made an outstanding contribution to the control of tuberculosis or lung disease by their scientific work or actions in the field. The Union Medal today is being given to Professor Dennis Mitchelson, a true inspiration and living legend. As he says, science is a lifetime occupation, and he is still saving lives as he enters his 9th decade. Unfortunately, Professor Mitchison was unable to travel here today to accept the award, but he was able to pre-record this message.
Hello to you all. It is a great honor to receive the Union's medal today. When I first qualified as a doctor, I helped in the analysis of the results from the first clinical trial of streptomycin alone in the treatment of tuberculosis. Although the treatment failed because the bacilli became resistant to streptomycin, we later found that resistance could be prevented by treating with an additional 2 drugs. Following successful results in the treatment of mouse tuberculosis. We then explored the use of rifampicin and pyrazinamide. This led to the shortening of the treatment period from 1 year or more to only 6 months, and made the treatment affordable in developing countries with limited incomes. We now look forward to the use of new drugs to shorten treatment even further.
I'd like to call up to the stage Dr. Andrew Nunn, who will be accepting the award on behalf of Dr. Mitchison.
Just a few words from me. It's a tremendous pleasure to be able to receive this medal and to be able to take it back to Denny Mitchison. I had the honor of working with him for the best part of 50 years. Denny is pretty well as old as the Union. In fact, he was born in 1919. And it's true to say that his whole agenda over the 8 decades over which he has worked, from the mid-1940s right through to the present time, has been to actually to improve the lot of people with tuberculosis, in particular to develop more effective treatment regimens. You've already heard, in fact, that he was involved at the time of the streptomycin trial, which looked like at the first appearance to be a success, but of course it was a disappointment with the emergence of resistance to streptomycin. The following decade, in fact, he was working in Chennai, in Madras, as it was then, and was involved in that landmark study which demonstrated that, in fact, you could be treated just as effectively at home as you could in sanatoria. And in the years that followed, he was each decade involved in some further advance in the work of developing regimens and treatment for TB, notably in the 1970s, particularly in the development of short-course chemotherapy. And right up until about 4 or 5 months ago, he was continuing to publish, and indeed last year was the senior author on the paper that demonstrated the highly effective once-weekly regimen given with rifapentine. However, it was a great sadness when I heard, in fact, in July this year, that he decided to take early retirement. Many of us thought that Denny would go on forever. Having said that, he hasn't truly retired because, in fact, he still comes to meetings from time to time and is still wanting to contribute whenever he can. It's been a privilege to know him, and many of you here will have met him perhaps at times in the past. And I do feel that giving him this medal is a very appropriate way of acknowledging the very significant contribution he has made to fighting the scourge of tuberculosis. It's been his agenda for his whole life. We need more Denny Mitchisons. Thank you very much.
I'd like to call to the stage now Dr. Luchika Ditu, the Executive Director of the Stop TB Partnership, to announce the theme for World TB Day in 2016.
Good evening. I have 2 minutes and 3 messages. First of all, thank you, Jane, Jose, Stacy, Jove, Paul, Michael, all of you behind the scenes for a fantastic opening ceremony. It's crisp and clear and to the point. The second thing is that I'm wearing a t-shirt speaking about HIV only in this TB conference because I'm looking forward for the IAS in Durban, where all HIV activists will wear TB t-shirts, because we are here in this region especially. One, the disease is one, the person is one, the diseases can be more. So we need to stop compartmentalizing our work, and we need to do it together. So the real reason for being here is to announce that the theme for World TB Day 2016, and very likely 2017, and probably further, is End TB. And we will work together, all of us, to make sure that under this very generous theme, we will unpack in such a way that we will make sure that under the End TB generous theme, every year we'll look at different aspects and how we will be able together to hold hands in such a way that we will end TB. And in the same time, we are launching here, and thank you, most of you, for wearing it, and inspirationally today during the march, a lot of the activists and colleagues marching there, and friends and people affected by TB wearing this red pin, which I hope will be something that will unite all of us. We didn't have a ribbon, but now we have an arrow. It shows that we will not stop our work till we finish it, till we reach an end. And the end for us is the end of TB. Now, as a little joke, because it doesn't say TB or HIV or anything, which was on purpose, and we wanted this to be like the famous HIV/AIDS sign and the others, the ribbon, it's actually a very good entry point in conversation. It's a good hookup. People stop in the street and ask what it is. And depending on in what mood you are, you can be very sharp and crisp and say, this is showing that we will end TB, but also you can say, let me tell you more about TB and let's have a drink about it. So I encourage all of us to be united under a sign, but beyond any sign and anything, I encourage all of us to be united in spirit and to really do what we are all convinced we have to do, to end TB. Thank you.
Thank you, Luchika. Know, Share, Act. These principles have driven the work of the union since its founding 95 years ago. As we approach our centennial, we can commemorate our progress. But as this film demonstrates, our work is far from over. The union was founded in 1920 by a set of organizations, primarily ministries of health, who were passionate about ending the tuberculosis epidemic. I don't know of any other organization that puts all the pieces together in public health like the union does, with advancing science as well as taking that all the way down to how programs work on the ground for people. The union acts on its knowledge, brings people together to implement change, and by that ability becomes a leader in public health.
The union is always focused in three areas of work: know, share, act. Each of those in their own way is essential to conducting the work we do. Some of the prime examples of know is in the union's direct implementation of research.
What operational research is all about is the search for knowledge on strategies, interventions, tools which can improve program performance and healthcare delivery.
The continuum goes all the way down to clinical trials. In the STREAM clinical trial, it is an excellent example where the union is the sponsor of a trial that really has the potential to change policy and programs in a meaningful way.
Турч хичээлдэг айгуу ятгар байсан л та. Тэгээ одоо гоё байна. Гоё олж байгаа. Одоо тэгээд одоо үнэ магашгүй юм бол гарах гэж байгаа.
The STREAM is a clinical trial which is testing a shortened treatment regimen for MDR-TB, multi-drug resistant tuberculosis, against the current standard of care. So the 9-month regimen we're currently testing in STREAM Stage 1 is a huge step forward compared to the current regimen. 24 months of treatment compared to 9 months is a marked difference and makes a huge impact on patients' lives.
Инсулинтэй өвчтнүүдийг
эмчилгээний одоо энэ богино хугацаатай болгох тий одоо түүх болон одоо үлднэ гэж бодож байна. Эмээ уухтай нөхцөлийг бүрдүүлж одоо сайн дурын идэвхтнэр эмийн гэртэнд хөрвүүлж өгөх бас боломжийг олгож өгч байна. Мөн бодвол
тэгээд одоо ингээд над дээр өдөр болгоо ингээд ирээл миний эмийг харж уулгаал. Тий. Тэгэхээр бас айгу сайн. Тэгээд 2 жилийн хугацаанд гээ ярихаар хүмүүс нэг л ингээд урваагаал одоо яаж дахиад ингээд 2 жил ингээд үргэлжлүүлж уунаа гэд айгу ер нь хэцүү идэв. Эмнэлэгтээс хүмүүс ер нь тийм байсан. Намайг байх хугацаанд хүмүүс тийм байсан. Тэгээд би болохоор хажууд нь тэгэл 9 сар штэ гэл ингээд айгу оохот айгу сэтгэл санаач айгу гоё идэгс аахгүй. Тэгэхээр энэ айгу хэрэгтэй.
We believe that the patients in Mongolia will be in better hands as a result of the experience of the health system in the program in participating in this trial.
тэрүүгээрээ жоохон юу байгаа. Айгу өдрөг хяналт стримд орсон доо жоохон баярлж байгаа.
Ultimately, it's about the patients in affected communities. We have an obligation to work towards a shorter, more tolerable treatment regimen so that someday a diagnosis of MDR-TB won't be the catastrophic diagnosis that it is today. And it's only research that's going to get us there.
It's one thing to be an implementer, but to share this information is what's important. It comes at very different levels. You can have an individual learning at a course that we give. We also have our international conference every year. It's really a place where thousands of people can share what we know about the field. We also hold a conference on tobacco, where the people that are important in tobacco control get together. At another level, there's the whole communication piece that we're able to do. Part of that is working and sharing with partners, so they're able to do their own work. For example, in tobacco control, we teach partners how to work with their governments in order to advance the cause of tobacco control.
The union provides both resources and technical assistance to organizations like mine. So with support from the union, we in turn have been able to provide aid to the government in developing tobacco control policies and legislation. With a grant from the union, we funded a study by the University of Cape Town, which predicted what would happen if tobacco taxation did not increase, or if it did increase, and what the impact on public health would be.
In working for an organization like the union, I have the contact with people really in country to see what the situation is on the ground.
We have decided as South Africa to look at which people in the population, which key groups are most vulnerable. Number one are inmates in correctional service facilities.
Today we went to Pollsmoor Prison in Cape Town, South Africa. What the union did was bring media to really highlight that prisons are a place where there is an increased rate of tuberculosis compared to the general population.
We launched a program for screening and intensive management of TB. Every inmate, every person who enters the prisons must be screened. That never used to happen in the past. Those who are incarcerated must be screened twice during their period of incarceration.
I was coughing for 4 weeks, but I didn't go to the clinic. I was outside. So when I come here, they found me. They say I've got a TB. So after that, they say, oh, they're going to take me for the treatment for 6 months.
I was losing weight. I was coughing.
I think that's the story, that there's access to healthcare anyway, and that access to healthcare is needed everywhere. So I think for me, what was important about the visit today and what was important to cover the story is to understand the lives of the inmates. How are they affected by TB? To what extent are they getting treatment? And most importantly, how do they feel about that?
I'm feeling better now. I'm feeling healthy because I'm finished my treatment this month.
The reason why the union did this media tour is to really shine a light on the particular issue. It's not just an issue for South Africa, it's an issue all around the world. Anywhere you go, a prison, a jail, is a place where you're going to find tuberculosis if you look for it.
To me, it's really interesting that the union does have this ability to act at a very high level and bring the people of power together, but yet at the same time still has the compassion and ability to bring care to the individual patient who needs it. ACT also is to advocate and advertise the advances in public health, especially in tuberculosis, and motivating that political will that's going to give us the resources that we need.
Stand up and call on the people who represent you to act. Stand up and say 200 years is too long. We can beat TB in a generation, and we must.
It's the implementation of programs, of taking the science and seeing how they translate into the real world.
By the year 2030, low and middle income countries will account for 3 out of 4 people who die from tobacco-related illness. We must end the practice by which governments themselves are the tobacco industry. Looking across this room at all of you gathered here today, I know that we will prevail.
What is knowledge if you don't use it? We've actually gone to the ground and shown, I think, the world how to try to get some of these things done.
The TB epidemic in the country is largely driven by HIV, where we are looking at 70% of TB patients being co-infected with HIV, which really becomes a priority area of focus.
The union came up with the idea for the integration of TB and HIV. This integrated TB HIV care has worked, and now this has been adopted by the Ministry of Health as good practice.
The patient doesn't have to access services at different service points. Everything would be under one roof.
My name is Constance Manwa. I've been treated for MDR TB when I was pregnant with my firstborn baby. That's when I was tested for HIV. I tested positive.
The union provided mentorship. They provided the medicines in the earlier years, and they provided the support to ensure that the program went by.
Everyone was trained here by the union. Every nurse is taught everything about HIV patients, about TB patients.
Just went so well, and I started gaining weight, started gaining strength, started gaining confidence, started feeling alive again.
We have demonstrated that indeed we can provide integrated and decentralized TB/HIV services within resource-limited settings.
This country is one of the success stories of managing HIV properly. As we begin to control HIV, TB prevalence is also now beginning to come down.
I was successfully cured. My son is bouncing, he's 6 years old now. We are happy. Being HIV positive is not the end of the world. You can still do wonders. You can still do wonders as long as you accept your status and move on, and you learn to live positively. You learn to live positively.
All right, it gives me great pleasure now to introduce a performance from the young people of the Amy Beale Foundation. The foundation runs after-school activities for young people living in challenged and vulnerable communities within the Western Cape. Activities they run include literacy, numeracy, HIV/AIDS prevention, dance, sport, drama, music, plus many more. Please welcome to the stage the Amy Beal Foundation.
As my young friends say, that was awesome. So, in closing, I just wanted to remind you about a few important events coming up this week. Saturday, the union holds its General Assembly at 5:15 in Auditorium 2. This is where the members join in setting the course for the new year. It's also where the honorary memberships are awarded and the winners of the Christmas Seals contest are announced. Be there. Also, I hope all of you will attend the closing session and the reception on Sunday from 3:15. That's going to be right here. Now, join me for tonight's welcome reception just outside the auditorium, and let's start building that new agenda. Thanks.